So I want to tell you a little story, and this is 100% true. Happened to me a few months ago. I got a phone call about 6 o'clock in the morning from one of my former residents who was crying, bawling in tears. And she told me that she had just killed a patient. Now, I knew this resident. I thought she's being a little too emotional, maybe exaggerating a bit much. I said, you got to tell me more about this. I know you didn't kill a patient. So a little background on this resident. After training with us, she went up to a small critical access hospital in the north. Critical access hospitals, if you don't know, are very small. Skeleton staff overnight, one doc, one nurse, a respiratory therapist, usually a tech for radiology has to be called in. Very slow, just there to stabilize patients. And that's where she was working one night. She got a call from EMS saying, we have a bad asthmatic coming in. And all the paramedics said is that this patient looks terrible. No vitals, will be there in 5 minutes. Well, when the patient came into the ED, they were waiting, and this patient looked terrible, as described. He was diaphoretic, he was retracting. He was a 35-year-old asthmatic patient that was working to breathe. The first thing he said to her was, please intubate me. That's how bad this asthma exacerbation was. He had been intubated before, but she knew that was the wrong move to do for this patient. She got the continuous nebulization on, she got the steroids, she gave the magnesium, and she stayed with the patient for about 15 minutes. And he looked at her again and said, please intubate me. Now, we know that intubating asthmatics are not good, but she blinked. She got scared, new attending in the middle of nowhere, and she went to go tube this patient. Meds were pushed. This was not an easy airway. Took a couple passes, and eventually the tube went in. Standard setting went in on the vent. Rate of 15, PEEP of 5, tidal volume of 500. She was not paying attention to that. And on the next blood pressure cycle, hypotension, patient became bradycardic, and that patient coded. 35-year-old male with asthma, coding in front of you as a junior attending. So she jumped on the chest. They started doing ACLS. 15 minutes later, no return of spontaneous circulation. 30 minutes later, nothing. An hour into the code, still nothing. She went to 1 hour, 45 minutes coding this 35-year-old male before pronouncing him. It's upsetting as a new attending to have this case. I can't imagine how that feels. The life-threatening asthmatic is a different breed of patient than your standard asthmatic who you give a couple nebs to and send home. It's a completely different person. The physiology is different. Those patients have respiratory distress, but they also have hemodynamic compromise. And every second that you have with that patient counts. And what you do is important. Now, I want to do a little exercise with you, and it's a good thing it's first thing in the morning. So can I ask you all to stand up? And I just want you to pay attention to your breathing as you're doing this exercise. You can even take a little stretch. It's all good. All right, here we go. Take a breath in. Now breathe out. Take a breath in and breathe out. All right, stay standing for a second. Your normal breathing pattern is just this. Everything above the baseline here, this is a flow waveform, is your inspiration. And everything below the baseline is expiration. And all of you in this room, and normally, have this pattern where at the end of expiration, you come back to zero flow. All right, here's what we're going to do next. Take a breath in. Now breathe out. Now breathe in and breathe out. Now breathe in and breathe out. And breathe in and breathe out. And breathe in. And some of you are about to pass out, so stop. You can sit down now. Thank you. And this is what happens with the asthmatic that comes in status. They can take a breath in, but they can't get that air out. And over time, what builds up is air trapping, auto PEEP, dynamic hyperinflation. And this causes difficulty with breathing, but this also causes hemodynamic compromise. And this is how it looks on the flow waveform. So everything going in is just fine, but what's coming out is breath stacking. So how are we going to treat our patients? The medication that should be the go-to after you do all the standard stuff should be epinephrine. Epinephrine is the OB, the original beta agonist. All right, it's old school. That's what they used to give before they had albuterol. So why wouldn't we just go with albuterol if we have a newer agent? The reason why is because the person who has a silent chest, the person who has having difficulty moving air, isn't getting those albuterol particles down into their airways. So effectively, it's just getting the main bronchus. You want that to be down the alveoli and cause muscle relaxation. And when that person comes in, the only thing that's going to work is something systematic, like epinephrine. Now you might say, well, that person's tachycardic, they're hypertensive. I don't want to give them epi, I'm going to make them worse. But the reason why they're tachycardic, the reason why they're hypertensive is because they're about to die. And when you give them epinephrine, there's lots of data that shows that those vital signs actually get better. So give them beta agonists, but give it in a way that their body can receive it. Albuterol is not going to work for them initially. I love Heliox, said no respiratory therapist ever. Heliox is a blend of oxygen and helium. And the way Heliox works is it makes the gas less dense as people are breathing it in. When a person comes with asthma and they have tight airways, there's turbulent flow. It makes it more difficult to breathe. It's harder to deliver meds distally. So by giving Heliox, theoretically, you make the air a little bit less dense, easier to breathe in, meds get delivered, it becomes easier to breathe. It is very controversial whether or not Heliox works. If the tank is sitting there next to my asthmatic patient, sure, I'll give it to them. But the reason why I don't routinely ask for Heliox is because the respiratory therapist has to go somewhere in the bowels of the basement of the hospital and find these tanks and bring it back. And I need that person on my team next to the bedside. So with marginal evidence, I'll pass on the Heliox and I'll have that respiratory therapist at the bedside. Now, what I do for all my asthmatic patients, the severe asthmatics, is I chill them out. I got to get them chill. And here's why. Because there's a cycle that happens with asthmatics. They are anxious because they feel like they're going to die. And when you're anxious, you become tachypnic. And when you're tachypnic, you have less time in expiration. And when you have less time in expiration, you start to have that breath stacking we talked about before, which makes you more anxious and makes you more tachypnic. And then you have more breath stacking. And that cycle continues and continues. So the patients are working against themselves. I use ketamine in subdissociative doses to make my patients chill. It slows down their breathing. And ketamine is nice because it causes bronchodilation distally. So I have another bronchodilator working on a different receptor in addition to the epinephrine that I'm giving. Chill your patients out with the ketamine and help them to breathe. Non-invasive, it's still somewhat controversial, but most resuscitationists will tell you it is a good thing to use. The people that oppose non-invasive ventilation, specifically we're talking about BPAP here, will say, asthma is not a problem of inspiration, it's a problem of expiration. So why do you need to give them inspiratory support? The reason why you need to give them inspiratory support is because these patients, when they hit your door, have a stopwatch on their intrathoracic musculature. They are starting to tire out. And you only have a finite amount of time to get all the medicines on board and reverse the bronchodilation. So non-invasive helps me to get them a little bit of assisting with their breathing to stretch out that time that their muscles have before they fatigue and get intubated. Non-invasive is a very good idea for those patients. I put it on right when they hit the door. I don't wait for them to fail the other medications. If they look terrible, they're getting non-invasive right away. Now the question is, when do you intubate? I've always been told that the indication to intubate an asthmatic is never. Unless you have to, then do it quickly. And that always made me very confused. When do you intubate an asthmatic patient? This is one of those questions that there's no lab test for, there's no vital sign. You just have to have clinical experience. And so over the years, I've seen a lot of these patients, and I've talked to my friends who have seen these patients. And what we all come to is that when you have the asthmatic that's working to breathe, let them breathe on their own. Don't intubate them. But when it comes to the point where they start to tire out, they become somnolent. That's when their CO2 is starting to rise, and it's very hard to get those people back. That's not the time to put the non-invasive and see if you can perk them up. They're probably on their way down, and now is the time to intubate those patients. But it is a very risky endeavor. When you intubate those patients, you should remember that the person with the grayest hair and the most experience should do the intubation. If that's you, wonderful. If it's not, take that pride and put it to the side and get your colleague who can do it quickly, because first pass success is key here. You're going to have all your adjuncts, you're going to have your bougies, your video laryngoscopy, great. But remember one thing, go big with these tubes. The tubes cause resistance. So for a male, I go 8.5. For female, I go 8. So I want a big tube in the airway. I want to decrease the resistance of the airflow going through. And in addition to that, these patients, when they go upstairs, they might be bronched. They're going to have lots of secretions. And I want to be able to get a suction catheter or bronchoscope down there without causing resistance in the airway. So go big. Post-intubation, you might find that's very difficult to bag. And there may be a tendency for the therapist to even really squeeze down. That's the wrong move. you're going to cause barotrauma for that. So nice, slow, gentle respirations. Get the inspirations in nice and slow, don't cause trauma, and give them plenty of time to breathe out. Let's talk a little bit about post-intubation medications. These patients are not going to be what we talk about when we talk about a RASS scale of 0 to -2. Keep them light, keep them interactive. These people, you got to take them deep. Good analgesic first, whatever your opioid of choice is, but then go deep with them. I like to use propofol because propofol gets them really deep, but it also causes bronchodilation by itself. If you want to use ketamine, by all means use ketamine. It's a great agent after intubation. But this is what I use for my patients. Get them nice and deep. And then on rare occasions, when they're asynchronous with vents, you may have to paralyze these patients. It's not something we like to do because paralysis plus steroids causes critical illness myopathy. But if you can't get your patient synchronous with a vent, then a dose of paralytics is okay. This bronchospasm is going to go away in time. You just have to wait for everything to kick in. How are you going to set up the ventilator? This is just what I've gathered by talking to a lot of smart people through my career. I go with a volume mode of ventilation. If you're a pressure mode kind of person, that's fine. But I find that volume is the universal language with vents. So no matter where you are, people understand volume. So my initial respiratory rate in a volume control mode is a rate of 10. I want to give that patient enough time to get their expiratory phase out. And if I look at that waveform that I showed you before and they're still air trapping, I might even slow down their rate a little bit more. I like to go with a volume of 7 cc's per kg, okay? 6 to 8 is what we try to go for, and I aim in the middle only because if they're still having trouble with air trapping, I can click them down. And if they're doing okay or they need more, I can go up. But I just go right in the middle for 7. I go for a PEEP of 3. These patients have their own intrinsic PEEP already built in, so they don't need any more PEEP. And I think there's at least some theoretical benefits to keeping your PEEP on the lower side because we want to make sure that they get the expiratory flow out, and giving any PEEP might counter that air from coming out of their airways. You're going to have to change your peak pressure alarm because these patients have high resistance. The peak pressure alarm is going to go high every time they take a breath, and then you're going to have to run over the ventilator to make a maneuver. So be sure you set your peak inspiratory pressure higher than normally set, and your therapist will know how to do this. But always keep an eye on your plateau pressure. An elevated plateau pressure is a bad thing for these patients. It indicates that they could have a pneumothorax, but your peak pressures you can allow to go a little bit higher. And then finally, to make sure that you decrease your inspiratory time and increase your expiratory time, you're going to increase the flow rates for every breath that you give. The less time it takes to get your full breath in, the more expiratory you have by default. Your goal when you have the flow waveform, and this is what I encourage everyone to look at when you have an asthmatic, is you got to know this waveform. You see how there's still breath stacking down there? You want to go from this waveform to this waveform. At the expiratory flow comes right up to the baseline. Now, all those changes are going to lead to hypercapnia. And a respiratory therapist or someone's going to come up to you and say, but look, the CO2 is high, the pH is low. Permissive hypercarbia is okay here. And I don't have a number to tell you how low to go, but I'm absolutely fine going to 7.1 in my pH and let my PCO2 go high. Because in time, they'll be able to ventilate this off. But I need to do these changes to make sure that this person breathes and gets oxygen. So that's critical for me. If you've ever heard Chris Nixon's talk, he talks about euboxia, trying to avoid getting people's numbers to the right state. But again, permissive hypercapnia is absolutely okay for these patients. Now, after paralysis and after you do all these things, some patients will still be sick. And you might have to call your anesthesiologist. They're already tubed, so what could you possibly be asking them? For volatile anesthetics. Inhaled anesthetics in the OR can reverse bronchospasm in some cases. So it's worth a call to them if your patient is still not synchronous with the vent and still in trouble. And of course, everywhere has ECMO, every center in the country. You guys have ECMO, right? I'm kidding. ECMO is one of these things that us academics talk about all the time, but the reality is not everyone has it. But what you may be seeing in a hospital near you is extracorporeal CO2 clearance. It's ECMO just for CO2. And these are 14 French catheters that go in the groin. You hook them up to the machine, and this might work for our COPD patients. This might work for asthmatics. They can oxygenate just well, but they can't clear out their CO2. So it's a way you can scrub their blood out of CO2 and maybe even not intubate them in the first place. The last thing I'll close with is what happens when you do all the right things and your patient codes on you. The first move should not be to jump on the chest and do CPR. Here's the reason why. that person's shock is obstructive. It's from dynamic hyperinflation. So your first move before pushing on the chest is to decompress that obstruction. Push down on their anterior chest and get that compartment syndrome of the chest, that obstruction, away. The next move you want to do is make sure that the tube is not kinked or obstructed. Do a quick ultrasound to look for pneumothorax. And once you've removed all of that from the equation, then you should push on the chest. These should only take you a couple seconds anyway. But if you push on the chest in a dynamic hyperinflated lung, you're never going to fill the heart up anyway. And don't forget, with the amount of albuterol and epi that you've given, you could cause hypokalemia that could cause arrhythmias. So it's important to send off stat labs as you're initiating the code. The life-threatening asthmatic is not a patient you're going to see on every shift. It might be a patient you see once a month or even once a year. But when you see that person, the things that you do are very important, and you must do them quickly and in an organized way. So take these tips from the lecture that you heard today, and please remember them the next time you have that person with life-threatening asthma. Thank you.